With over 25 years experience as a registered nurse, Bobby has been working in hospice for approximately 20 years. Her hospice career began in 2005 as an intake and admissions nurse for a large nationwide hospice company. Her love for hospice was immediate, and she knew that this was her professional life calling. She has worn many hats in her hospice career. Her true passion is meeting for and caring for the patients and their families. She believes it is an honor and a privilege to share in the patient's final act of living. It is truly an honor to have Miss Bobby here with us today to share all of her important insight and information. So I'm going to go ahead and mute myself, and Bobby, I will let you take over.
Okay. Hello, everyone. Thank you for having me today. I would like to add to the intro that 10 short years ago, so I've been in hospice for over 20 years now, but 10 short years ago, Dana McBride and I decided to take a leap of faith and open Bridgeway Hospice. We are both nurses, and we have a love for hospice. This was our dream, to own our own hospice agency and provide care and comfort to our communities. Of course, all hospices must follow state and federal guidelines, but at Bridgeway, we put the patient first. And as our slogan says, at Bridgeway, it's personal, because it is. So when we first opened Bridgeway, we only had 2 patients. My title was the director of nursing, but of course my job encompassed so much more. I was the receptionist, the HR person, admit nurse, on-call nurse, pretty much everything. But as we've grown over the past 10 years, we now have 3 locations, Baton Rouge, Lafayette, and Plaquemine. I'm very happy to say that my new title is the Chief Clinical Officer, and I'm responsible for all aspects of patient care and clinical services as it pertains to patients and their family. We currently have over 110 employees. We have 3 DONs and 6 ADONs that report directly to me, and they oversee the day-to-day care. I'm here to provide support and education. A lot of conversations entail the care of our Alzheimer's and dementia patients. So at this time, I'm going to go into discussing the specifics of the Alzheimer's disease process and end-of-life care. So what does Alzheimer's look like? It's a type of dementia that worsens over time. It affects memory, thinking, behavior, all aspects of day-to-day living. Symptoms will eventually worsen as the disease progresses. So what symptoms should you expect to see? Initially, you'll notice mild to moderate memory loss, problem solving and planning becomes more difficult, difficulty completing familiar tasks such as driving to a familiar location, making grocery lists, or keeping up with activities that should be second nature. Confusion with time or place, or maybe both. Vision problems such as reading difficulty or balance. New problems with words while speaking or writing. They may have difficulty recalling names of items or calling them incorrect names, misplacing items. Oftentimes people will accuse people of stealing things. I remember my grandmother doing this. She loved costume jewelry, and she would lose one earring, and she was adamant that somebody stole that one earring. But they also may exhibit poor judgment or have difficulty making decisions. They may pay less attention to their grooming or keeping themselves clean. When I first started hospice, and still today, this is such a big concern for so many of our patients and their families. And involving hospice certainly helps the caregivers get assistance with getting the Alzheimer's and dementia loved ones the care that they need with taking a bath or to brush their teeth. They also may withdraw from social activities or work because they have difficulty keeping up. The Alzheimer's dementia patient will make excuses not to attend events or work because they begin to realize they can't keep up with the task at hand. They may have changes in mood or personality. They often become confused, suspicious, depressed, fearful, or anxious. They become easily upset and will sometimes even lash out. This is common with Alzheimer's and dementia patient. So what will the patient need from the caregiver? Unfortunately, with the Alzheimer's patient, they will eventually need total care from a caregiver. Bathing, medication administration, dressing, feeding, they will become where they can no longer be able to be left alone. Eventually, they will need care with walking, toileting, and all activities of daily living. The care will become very similar to caring for a young child and eventually will become like caring for an infant. So, what resources can the caregiver begin to expect or need or plan for? The families will need to consider and begin planning for changes to come. Some of these changes are going to be very evident, while some of the changes that I mentioned before may come on slower. However, the Alzheimer's patient will eventually no longer be able to live or stay alone. They may need sitters because they can't live independently anymore. They may need to move in with a family or have a family member move in with them. Um, it may become an unsafe environment for them to live alone or without assistance. Some families choose an assisted living option, and others may eventually have to choose a nursing home. There are insurance policies that have long-term care inclusion that help pay for some of these costs, but those are things that you generally have to purchase in advance because once your loved one is diagnosed with this, you'll no longer be able to get that policy. Most times. Some people may qualify for Medicare or some of the Medicaid waiver programs that provide assistance. These are generally things that are based off of income. And of course, when the time comes, the need for hospice. Alzheimer's Services, of course, is a resource. They offer many resources. Some of those include, but are not limited to, the helpline, caregiver education, support groups, lunch and learns, Charlie's Place, respite reimbursement, just to name a few. End of life care. What is considered end of life care? End of life is when the patient is diagnosed with a terminal illness where there is no longer a cure for the disease, specifically Alzheimer's or dementia. Most times, a patient will require the care received by hospice. The definition of hospice is when a patient has a life expectancy of 6 months or less if the disease runs its natural course. Now, this can be very difficult to determine if a patient has only 6 months left to live. So Medicare has set up guidelines for each disease process. For Alzheimer's dementia patients, it's classified when the patient is at or nearing a stage 7 of the FAST scale, possibly even a 7C or beyond. So you may ask, what is the FAST scale? It's a functional assessment staging test that we use as healthcare providers to gauge when a patient is in the advancement of their Alzheimer's disease. The scale starts at 1 and ends at 7. Once the patient's approaching a 7 on the FAST scale, healthcare providers consider the patient approaching appropriateness for end of life and hospice care. Just to let you know, there are 6 stages additionally after when you get to stage 7, they're quantified as stage A, 7A through 7F. So when is a patient appropriate for this? A patient with Alzheimer's or dementia would be considered appropriate for hospice when they typically are no longer able to ambulate, or they may be experiencing frequent falls because they forget they can no longer ambulate and try to ambulate and fall. They have a limited vocabulary. They're unable to effectively communicate their needs. By the time they reach a 7C, which is non-ambulatory, or a 7D, that they're unable to sit up independently, they are absolutely appropriate for hospice. They should no longer be able to dress themselves without assistance or bathe themselves. They will likely be incontinent of urine and maybe stool, maybe some of the time or all of the time. Dementia patients will also have what we call comorbidities. So, for instance, they may have experienced such things as aspiration pneumonia, frequent or recurrent urinary tract infections, possibly sepsis or wounds. They may have had frequent hospitalizations. They may have experienced weight loss because they're refusing or their inability to eat enough to sustain their weight. Or they may have weight gain because they forget that they ate and will eat again. We've seen a lot of this over our years in hospice. There are several benefits of getting hospice involved, as having trained staff such as RNs, social workers, chaplains, certified nursing assistants, and volunteers are available to provide support and care as needed. Our team of trained professionals are there to prepare you for what may be next and to be there to walk the family through the process. We are trained to pick up on things. Sometimes they're subtle changes. For instance, they may experience the signs and symptoms of a UTI. We're experienced to recognize this and we're able to treat it sooner. Our goal is to prevent hospitalizations. So often when Alzheimer's or dementia patients are hospitalized, they have a huge decline just going in the hospital because they are in a different environment. They like the repetitiveness and they like to remain in their own comfortable environment. Our goal is to recognize these things and catch it and treat it before it gets to the point that hospitalization is needed and the symptoms are exacerbated. We also will continually provide education on what to expect in the disease process. We will educate the family on what will happen and how we will treat it and what you as a caregiver can do so that you can be prepared. Our nurse visits at least once, at least weekly and more if needed. Our aides are all certified and trained to recognize these types of changes also and report these changes to the nurse. The aid services are provided to hospice patients to help keep them clean and keep their environment comfortable. We also offer spiritual counseling and social services by master prepared social workers who assist with outside resources and help with things such as financial aid. And then our volunteers are available to do a variety of different things. I would like to share with you two of my favorite patients. One of them, both of these patients had dementia. The first one we had for a very short time, maybe a month. I was his nurse and he was at the very end. I'd walked into his room and he had been pretty much comatose for the last day or two. He was lying in his bed, his eyes closed. I spoke very softly to him and I said hello and I called his name. Without ever opening his eyes, he said, "Hello, Bobby." His three children were sitting around the bed and they could not believe that he remembered my name. He had not spoken or remembered who they were for weeks. It truly touched me that he knew who I was and recalled my name. Another one of my favorites was a little gentleman that resided in a memory unit at an assisted living. He had dementia. He also had macular degeneration, so he was almost blind. When I would visit him, he always thought that I was his daughter. His daughter was blonde and was a nurse also. So I would arrive and sit next to him and he would pat my leg and he'd say, "There's my girl." The other residents who also had dementia would say, "You're such a good daughter." So I just went along with it to let him think I was his daughter and the other ones to think that I was his daughter too. But those were two of my favorite patients. They're all my favorite, but um, clinically, what to expect at the end of life. At the end of life, some of the things that you should expect are significant personality changes. They may become less active, generally poor food or fluid intake, less verbalization. They may be unable to ambulate, unable to care for themselves, unable to recognize loved ones, even those closest to this person. They may have the not have the ability to make their needs known, so they no longer can voice that they're hungry or in pain or that they have to use the bathroom. In the last 6 months, some of the things we've already discussed, but they may also we also like to discuss eliminating some of the medications that the patient has been taking. The medications often become less and less effective, or many times the side effects outweigh the benefits at this stage in their life. So therefore, it would be beneficial for the patient to stop some of these medications. So we'll educate the caregiver on these changes that will, be the best for the patient. The last month of life, we usually see that they have a decreased and possibly no food or fluid intake. This is often one of the hardest things for our families to accept, because many times, especially here in the South, we think that you have to eat to get well. Well, often this is truly not the case at end of life. Actually, the opposite is true. My philosophy is if they're refusing food, this is their way of telling you they don't want it. So please don't force them. There's written scientific documentation that supports when forcing a patient to take food or fluid at the end of life, there's stress that puts additional stress on the body. What goes in must come out. So the body actually has to work harder to process this food and digest it. I always tell my families that if the patient wants something, by all means give it to them. Do not deny them. But if they're clamping their mouth shut, they don't want it. This is their way of saying, I don't want it. Please don't force them. Additionally, forcing food intake can result in aspiration or possibly even pneumonia, which could cause the end of life to happen sooner. Some of the other signs that we see is increased sleeping, a change in mood, increased fatigue and weakness, withdrawal. The hospice team continually provides education and support, preparing the family or caregiver on what to expect, what changes are to come, and how we will address those changes and treat those changes. In the last week or two, they may experience increased agitation, or we even see what we call terminal agitation. This agitation is different from their normal anxiety. It may be more difficult to control. Therefore, hospice would need to intervene to help with some of these symptoms. They oftentimes will pick at things in the air. They may enter what we call the transitional phase. There may be a change in their vital signs. The blood pressure usually will begin to drop. And initially their heart rate will increase because it's trying to make that blood pressure come back up. The body temperature fluctuates between hot and cold because the brain is losing its ability to regulate the body temperature. Their hands and feet may be significantly cooler than the rest of their body. Their skin color may begin to change. It may take on more of a bluish tint. Their breathing usually changes. At first, their respirations may increase and then they start decreasing. In the last days of life, sometimes patients will have a sudden surge of energy. I often explain this to my families that this is very much like the laboring process. They're just laboring into a different realm, whatever their belief system may be. Sometimes you may not notice this at the time that is occurring, but hindsight, you look back and realize that this is what was occurring. The changes in the vital signs in the last couple of days, the blood pressure continues to drop, and now the heart rate has begun to slowly drop, and it will become where it's even difficult to feel their pulse. Their breathing may change. They may experience what we call Cheyne-Stokes respirations. This is an abnormal breathing pattern that's characterized by progressively deeper and sometimes faster breathing, followed by a gradual decrease that results in a temporary stop in breathing, which is called apnea. The apnea can last sometimes up to 30 to 45 seconds that they go without breathing. And then, the last thing, and it sounds terrible, but it's a clinical term called the death rattle. This may also be present. Not all patients experience the dying process the same. Some may experience all of these symptoms, and some only a few. We have experienced all of these in our years with hospice. In my personal experience, I do find that patients who don't consume as much food or fluid in the last week or two of life don't tend to have the death rattle nearly as bad as ones that, do get more food and fluid right up until the very end. Their eyes may be open or semi-open. They may have a glassy appearance. Their feet and hands may also take on almost a purplish color. The blood pressure and the heart rate will continue to slow until the heart eventually stops. At this time, I feel that my patients have received the ultimate healing. They are no longer suffering. Our job is to prepare you and your loved one for the end of life. Grief is real, and grief can start while the patient is still living. Oftentimes, with Alzheimer's and dementia process, the loved one begins to grieve their loved one before they have passed, because the Alzheimer's disease process is stealing our loved ones from us daily. They start to realize things, the patient will start to realize that things are different. You start to realize things are different. you and your loved one are losing control of what this disease has now taken. Our hospice wants to be there for you and your loved one. We also offer bereavement support and even pre-bereavement support to our families and caregivers. The value of being educated and prepared. At Bridgeway, we are here to help you with creating moments that matter and eliminate the chaos, the panic, the struggle, and to help you with a plan and resources. We want to help you be prepared to navigate through the disease process with resources and to help you stay a step ahead to allow you, the family, quality time with your loved one, the patient, our patient. Okay, I'll be happy to take any questions that anybody has now.
Okay, Bobby, we have a few questions in the chat.
Okay.
All right, let me just pull it up for you. All right, can Alzheimer's patients qualify earlier for hospice and or palliative care?
Typically they need to be in the 7, at least a stage 7, mainly because the trajectory or life expectancy of an Alzheimer's patient can be from 7 to 12 or maybe even 15 years. So where hospice doesn't have, it's an unlimited benefit, they have to meet that criteria and they have to continue to decline and continue to meet the criteria. So if you admit them sooner, they may end up being discharged off of services because they're not declining fast enough and then be able to be readmitted later.
Okay. All right. And can you talk a little bit more in depth about stage 7 of the disease and what that looks like, where people are during that? Because, we know everybody declines and goes through this differently, but some of the things y'all see most often.
Right. So typically they are having difficulty ambulating. And like I said, they may no longer be able to ambulate at all, or they forget that they can't ambulate and they fall, or they forget how to use a walker. A lot of times families will ask, can we do physical therapy? And we can, but the problem is the Alzheimer's and dementia patients aren't going to remember that what they were taught to use those. So it's hard for them to progress or improve with physical therapy. They also, it is expected that they are not able to dress themselves. And, when I say that, can they go to the closet and pick out an appropriate clothes and put those clothes on? In a stage 7, they can't. They need either the clothes laid out for them, they need to be shown how to put it on, they forget how to button it or zip it, or even how to do their, if it's a button or zipper on pants, they forget how to do those sorts of things. They cannot effectively communicate their needs. So they're not able to voice, I'm hungry, or I'm in pain, or, voice that they need help with something.
Okay. Thank you. We have a few more questions, and I encourage anybody that's participating today, we do have some time, so please ask questions, put them in the chat, anything you can think of. More than happy to get your questions answered for you. And thank you, Bobby, too, for all your information. Our next question is, what qualifies an Alzheimer's patient differently from a patient actively passing?
Well, it's not really different. It's just at what stage that we admit them. One of the most common things that I hear from families is that I wish I would have done this sooner. So often people are afraid of hospice or the stigma that hospice has when they finally agree. And most of the time it's just because they're exhausted, they're worn out, they're like, okay, I need help, I give up, come help me. When we go in and start helping, they realize, oh my gosh, I didn't know all of this care was available, and I wish I would have done this sooner. So sometimes that patient that is actively dying, or if we admit them a little bit sooner before and that's when we want to admit them before they're actively dying, because we want to build that rapport with that patient, with that family, get to know them. We want that family to trust us and get to know our patient, to be able to educate them of the changes that are coming. But so there's really nothing that differentiates if they qualify at end of life or when they're at the stage 7. Does that kind of what
Yeah,
you're
that helps, I think. Thank you.
okay.
Another thing too, I know that hospice is very helpful with is the provision of medical equipment. That's something that can be very expensive. Can you talk a little bit about some of the equipment you guys most commonly help to provide, and then how those can make life a little bit easier for families?
Absolutely. So with hospice, we do provide any DME equipment that they would need. So hospital bed, wheelchair, maybe a Hoyer lift. That's a contraption that is able to pick the patient up from the bed and put them in a wheelchair, maybe to be able to get them into a shower. Over bed table, just like at the hospital. We also provide oxygen, any equipment that would be needed like that to make their stay at home in their environment more comfortable and safe for that patient. We also provide, we help supplement some of the supplies, such as incontinence supplies. So those that can get very expensive. So diapers or pull-ups, the underpads, gloves, peri pads, things like that. Sometimes when they're not eating as much, they may like to drink the Boost or Glucerna. We also help supplement that. We also help pay for some of the medications that are related to the diagnosis, as well as pain and symptom control meds. So if they have frequent UTIs, the UTI is absolutely related to the diagnosis, so we would pay for the antibiotic. Pain and symptom control is the anxiety or insomnia, constipation, those type meds. We also pay for that.
Thank you. Okay, the next question we have, we're getting some good questions. The next question we have, it says, if on hospice, does an Alzheimer's patient usually get off of brain enhancing medications?
It is recommended that they do eventually stop those. Brain enhancement medications, their indication is early to moderate onset. So at the time of their disease process that they come onto hospice, it's usually late stage. They don't have to stop it, but it's recommended to stop it. And like I had said earlier, a lot of times side effects outweigh the benefits. One of the side effects is decreased appetite. Generally at this stage, they have a decreased appetite. They're not eating. That is one of the big concerns. So oftentimes when we stop it, we see that kind of improves a little bit. So generally what we'll do is, especially if they're on two, like if they're on a Namenda and an Aricept, we'll stop one at a time and we do a slow wean to make sure that patient doesn't have an adverse reaction to it. If their symptoms worse, or we'll start it back. But if they tolerate it well, we'll go a couple of weeks, then we'll stop the next one so that we know how they tolerate each medicine individually coming off of it. Okay. Generally speaking, I see patients do better when they stop those meds once they're on hospice.
Thank you. Okay, the next question is, what type of communication accommodations are common within hospice for a patient who is no longer able to communicate well?
Well, we assess each patient individually and determine if there is a way to communicate. Like I said, we have trained professionals, so we're used to noticing, nonverbal pain cues to be able to determine if they're in pain, things like that. So generally it is difficult to communicate with them. And if they're not able to, then we have to go based off of our assessment skills or communicating with the family that may know this patient and may say, well, when she does this or he does this, it generally means this. So, but each patient is assessed individually for that type of thing.
Thank you. Another question, I know you've addressed this a little bit, but can you talk a little bit more about the support that is provided to the family directly? Social workers, chaplains, things like that. Can you go a little more in depth about how they can help?
Absolutely. So every discipline that visits the family, the nurse, the chaplain, the social worker, that visits the patient, if the family is not present, we will call that family member. before and or after the visit and discuss, do you have any needs? Do you have any concerns? This is what I saw on my visit, and collaborate that care to make sure that we are all on the same page. We also hold, it's called interdisciplinary group meetings every 2 weeks, where our whole team meets and discusses every single patient. The family is also invited to attend that meeting when we discuss the patient, so that we can stay abreast in what's going on. So we talk about what's happened the last 2 weeks and what's our plan for the next 2 weeks. So it's ever changing, our plan of care, as that patient changes. So all disciplines will communicate with the caregiver and educate them as the disease process declines, what to expect, what we think is going to happen, and then what we'll do as that happens, how we'll treat that.
Okay, thank you. Now, can you talk a little bit too about documentation? What should you have in line in order to, like, document wise, before beginning hospice, or just for the end of life in general?
Okay, so we have to have a physician's order for us to be able to admit a patient to our services. So that can come from your PCP, it can come from a neurologist, it can come from a doctor at the ER. And then we would expect to have medical records to support that that patient has dementia or Alzheimer's. And, and it's not just dementia or Alzheimer's. There's Lewy bodies dementia, Parkinson's dementia, frontal, temporal lobe dementia. There's all different types. We can take care of all of those kind of patients. But there would be, documentation in the medical records of diagnosis and decline that has happened.
Okay. And do you recommend families to have their power of attorneys lined up and all of those different types of things? That's something you guys can advise on if you get to someone that hasn't had that arranged before?
Absolutely. So, it's always good to have that, but if they don't, that is one of the things that our social workers can help facilitate.
Okay. All right. What next question is, what might be different for families who are losing someone with Alzheimer's or a form of dementia specifically than maybe a death for a person who doesn't have a dementia diagnosis?
Probably the biggest thing is that the patient can communicate themselves. So a cancer patient is likely going to be able to communicate things and tell us when they're hurting and how their pain is, where an Alzheimer's patient can't. So we're going to rely more on the family to tell us signs and tell us things that's going on, changes. Like I said earlier, that how this patient normally would behave or react or do, to let them know that something's going on. That's probably the biggest thing.
Yeah, thank you. Another thing too, you said, Bobby, that made me think of that, reminded me when you said that question too, is the grief is so unique for this too. It's so different because I think for a lot of us, the grief starts early. It starts when the person, loses memories, loses personality features about them that are special. And so that's another thing that I think is unique from a hospice perspective. Do you agree with that too?
Absolutely.
So the next question we have is, can you explain palliative care versus hospice care?
So the term palliative care has been around, and it's pretty much the same thing as hospice care. I think that hospice has a negative stigma in the community and society. And so they started using the word palliative care a little bit more, so that people would be a little bit more accepting. There's, some palliative care programs that are out. It does allow them to maybe still get some aggressive treatment and still receive palliative care. They don't receive the weekly visits by the RN, scheduled. It may be a once a month visit by a nurse practitioner, just kind of begin, baby steps for it. With Alzheimer's and dementia, I don't think the palliative care, that's, I think, kind of guided more maybe toward like cancer patients, where they still want to get chemo or radiation, even though it may be palliative chemo or radiation. So that means they know it's not going to cure them, but it may extend their life a little bit. They can still get that, but have, a social worker or a nurse practitioner available to answer questions and to kind of lay the groundwork for when they do stop that to go on to hospice care.
Okay. We have a couple of questions too, to kind of circle back to when you were talking about the stages a little bit, Bobby. The first one is, once a patient is in stage 7, can they still be at home and get hospice care if they qualify?
Yes.
Okay. Let's see, I saw another one about stage 7 as well. How long can a patient remain at stage 7?
Well, so it goes 7A to 7F, and 7 is the last stage. So we've had patients that have lasted a year, 2 years, 3 years, it just, and I truly think that a lot of times when patients are on hospice, we probably help extend their life a little bit, because we are catching those things, and before they get exacerbated, before they get to the point that they have to go to the hospital, before they get to the point that they become septic. So we're able to catch those and treat those where maybe that wouldn't happen, and they would end up a lot sicker and maybe pass sooner. So I do think that being on hospice, that's, they end up living a little bit longer than a patient without hospice.
Okay. All right. How can we do better for our memory care unit? That was the next question you had.
Oh, I think providing staff, making sure there's enough staff to care for them, having things that are familiar, in their setting. It's always, every time a patient, I've had a patient that moves like from a home to a memory care unit, there's usually a decline, just because it's a different environment. They may cry more, they may have more anxiety because they're very unfamiliar. So if you can bring things from their home into their personal space so that it's familiar to them, that would probably be one thing that could help. Visiting often so they see familiar faces. If they have hospice, having hospice before they go in that memory care unit, so that it's continuity of the same staff coming to see them, that familiarity of that.
That's really helpful. Thank you. We still have some more questions coming for you, Bobby. What is the process for getting started with hospice care?
So anybody can refer someone to hospice. Anyone can call. And a lot of times we do. We have family members that call and say, hey, I'm calling for information to see if my loved one meets criteria for hospice. We have community liaisons that will go out and meet with them, explain the hospice benefit, kind of do a preliminary to see if we think they're about ready. And then we can reach out to the physician and request an order, or the family can reach out to the physician and request an order, either way.
Okay, thank you. Okay, the next question is, how do you actually give families security that you are not there to speed up the death? Many people have the assumption that hospice means aiding in rapid death. I do think that's a common stigma. So how do you guys kind of counteract that?
Well, and that's part of, I said, admitting the patient before they're at the very end. So it gives us that time, because often we tell them, we become your new 911. Don't call 911, call us. We have a nurse on call 24/7. And it gives us time to prove that to them, that when you have an emergency, call us. We're going to come out and we're going to handle that emergency or that crisis or that situation that normally you may have called and brought the patient to the hospital, and to develop that trust and that rapport with that patient and that family. And so our goal, we do not hasten death. We do not, our goal is comfort, quality of life, and, teaching and minimizing those symptoms. And like I said, a lot of times those patients do actually live longer when they're on hospice, because we're able to catch those things that exacerbate their disease process.
Thank you. The next question we have is a little bit of a scenario. So it says, my husband has stage 4 glaucoma and kidney failure, possible stage 4. He has refused all treatment and will not allow anyone, including myself, to help him. I'm working with the hospice/caregiver groups here for myself, but feel helpless watching him decline. My only option is to call for an ambulance. Can you speak to that? Give maybe some advice on that scenario, Bobby?
Yeah, and that's hard. A lot of times people are stoic. And especially a man, he's probably been the provider, the head of the household. He doesn't want to give up that position and admit that he needs help with this. I would, say, can somebody come talk to you? Let them come out and see what's available. And so sometimes somebody different talking to him may be able to explain it in a way that he would be willing to accept it. Um, so a patient or a family can refuse or accept as much of the care. So I discussed the nurse, the aide, the chaplain, the social worker. Sometimes people don't want all those people. Sometimes only the nurse. So our regulation requires that at a minimum, the nurse has to visit at least once a week. So for him, starting out, would take baby steps and start just with the nurse. Now, the social worker, the chaplain would be available for the wife to provide support. Either she could meet with them at our office or on phone calls or wherever if they didn't, he didn't want them coming into the home. We're there for the family, but he's not ready for all of it. But it would at least begin a relationship to allow him to care for him, hopefully. I always tell people too, hospitals are not always conducive to getting better. They wake you up all hours of the night, they come in, they poke you, prod you, in and out. You don't get to rest well. Hospitals at their time are absolutely warranted and needed, but on when it comes to end of life and getting that care, the hospital may not be the best place. It may be at your home where we can go in and provide that care and prevent those frequent hospitalizations. And especially with COVID and everything, being exposed to other things that you don't want, to get.
Thank you. The next question is there anything hospice agencies can do to help if patients lose hearing aids?
Yeah, there's resources available. Our social work can work and see if there's, funds available or different grants or different things available to help with that.
Okay. The next one is, what are some nonverbal pain cues that a family member can look out for?
Typically, the most common one is grimacing, like they'll scrunch their forehead, they may grit their teeth, or they may, become stiff and like not want to like let you move them or roll them over. Or when if you go to move them or move a arm or a leg, they may obviously, grimace or cringe or cry out. But the most common is the burrowing of the brow and gritting their teeth.
Thank you. The next question is, what are some common things that a family member should be looking for to indicate that hospice is needed?
If they begin losing weight, if they start having frequent urinary tract infections, they're having difficulty ambulating or not able to ambulate at all, those are all, beginning signs that it's time to start looking into hospice.
Would you think increased falls too, Bobby? Is that something you guys see often?
Yeah, for sure.
Okay. All right. The next one says, my mother is currently at the end of life with hospice care. She stopped eating and drinking this past Sunday. I've noticed her gums bleed a lot. Do you have any suggestions? I clean her mouth with gauze dipped in peroxide and mouthwash.
Okay, so we, typically provide the little lemon swab tooth vets. The peroxide may be a little irritating, and the mouthwash may be too. So it may need to be a little something more gentle. So the tooth vets, some of them are pre-moistened and some of them are just a sponge that you dip in the water. And I would just, and the gauze may be irritating it too, just because it's a texture.
Mm-hmm. Okay. All right, and someone just added a little bit of information. I'm just gonna read it out loud. It says, for a reminder, palliative care is used in patients with chronic disease or condition. Their illness does not have to be terminal. So thank you for sharing that too. Is hospice covered under Medicare, or how is it paid for otherwise? That's your next question.
Okay, so yes, Medicare pays for hospice, and we accept what Medicare pays at 100%. So there's no out-of-pocket expense. We also accept Medicaid and private insurance, VA. All of those have a hospice benefit.
Thank you. All right, we have a couple more questions for you. For extended hospice care, how often does an Alzheimer's patient have to be recertified? How do you handle those recertifications?
Okay, so every patient, hospice patient, has to be recertified. There's a 90-day period, and then it's 60 days there, every 60 days thereafter. So after the first 2 initial 90 days, then a nurse practitioner has to go out and visit that patient prior to recertifying them. And then, so we're looking at what's happened over the last 60 days or the last 90 days and how they have declined. So they do have to continue to meet criteria, and they do have to continue to have some sort of decline ongoing to be recertified. So we meet together at that interdisciplinary group meeting and discuss that decline and how they've declined and why they still are appropriate for hospice.
Okay. And the last question we have in the chat for now, Bobby, it says, can you still provide care if an Alzheimer's patient refuses care? How does that work?
We can. And so a lot of times they are resistant to care. They're resistant to being bathed, especially when we first start, because they may not be familiar with us. So we just, we take it with baby steps. We get to know them. We don't want to force them or make them angry or make them combative. That's the last thing that we want to do. So we may just start out little, talking to them. But a lot of times, rather than going and saying, hey, do you want to take a bath today? Because the answer is always going to be no. We go in and we say, okay, it's time for your bath today. And we just kind of, take authority in that situation. And the most times they'll just kind of go along with us. They may not do that for the family, almost kind of like a child. They're not going to do it for mama, but they'll do it for a stranger, or for somebody, their teacher or somebody different. It's very similar to that with an Alzheimer's patient. It's just having that different person come in, and this is what we do every day. So our staff are trained on how to talk with them and how to deal with them and how to get them to participate in that.
Great. And we have another little scenario for you too, Bobby. It says, so instead of calling for an ambulance, I can have someone from hospice come out and check on him and maybe treat him at home. He does not have a doctor and does not want to be in the hospital, but does have Medicare. What do you recommend for that?
So that is absolutely somebody that we could take care of. If they don't want to go to the hospital anymore, that's a good sign that it's, time for hospice. They no longer want to seek that curative aggressive treatment. If we would have to have a physician's order from a physician, we have, if and look, we get patients that haven't seen a doctor in years and, adamant they don't want to go. We have, some nurse practitioners that make home visits that can go and make that initial assessment and where it's a medical provider to assess that patient and give the order.
Okay. All right. Well, that wraps up all of our questions. Bobby, you did a tremendous job answering all of those questions. Thank you so much. And you also provided a fantastic and informative presentation. I think this is one of those topics that can be easily intimidating, but is so necessary. And having this information early really makes such a difference in the long run. So thank you so much for taking time today. We have a lot of really nice comments in the chat. So I'm going to save all of those and I'll email them to you after the presentation. But just thank you so much. And thank you too to everybody who participated that submitted all of these awesome questions. That was so helpful too. So thank you everybody who joined us, especially thank you, Bobby, for taking the time out to do this today.
Okay.
Bye. Thank you so much. We'll see you guys next month.
Okay.
Thank you.